Well, this morning we are looking forward to a very exciting program, and the first panel is entitled Medical Care, Levels of Care Requirements for Long-Duration Spaceflight. We're very fortunate to have the panel moderator, Dr. J.M. Mike Duncan, who's the Chief of the Space Medicine Division in the Office of Space Life Sciences at Johnson Space Center. And I think he has an excellent panel as well, and he will introduce them. Mike?
Thank you, Dr. Asper. Good morning, everyone, and welcome to Day 2. Our panel today, we have several folks that I've worked with for a number of years, and I'm looking forward to the commentary that they will provide us this morning. First of all, we have Ellen Baker. She's an astronaut physician and the lead astronaut for medical issues at Johnson Space Center. She's had 3 previous shuttle flights. We have Dr. Mike Barratt, also an astronaut physician, and currently in probably what seems to him to be perpetual training, but he's training for an ISS mission. He's currently listed as a backup for Increment 18, and we look forward to, in the not-too-distant future, having him as prime crew on the International Space Station. Dr. Volker Dahmen is head of the Crew Medical Support Office at ESA's European Astronaut Center in Cologne. I've had the opportunity to work with him for a number of years on the Multilateral Medical Operations panel. Dr. Christian Otto is a remote operational medicine researcher, and he's had 2 prior one-year stays in Antarctica, the most recent of which was in 2005, where he was the South Pole Station physician. He's also a medical director in Ontario of the Ontario Telemedicine Network, and he's an emergency room physician. And last on our panel this morning, but certainly not least, is Dr. Yuri Voronkov. He is the head of the Department for Cosmonaut Selection at the Institute of Biomedical Problems in Moscow. So I think we have a good panel this morning. And by way of self-promotion, I'd like to point out after yesterday's conversation that I'm also an engineer. So, and relatively radiation hardened because I'm gracefully aged. And I'd like to point out one other thing about some members of our audience. It's been great to see our ISS crew members participate in this conference, a lot of whom, of course, are not physicians. And I think it takes a lot of courage to come into the lion's den, where we have flight surgeons, physicians, and researchers all looking at medical aspects. So I'd like to thank the crew that I was privileged to work with, Ken Bowersox and Don Pettit on Expedition 6. I'd like to thank them for being here. Well, as Dr. Alfred mentioned, our topic today is levels of care requirements for long-duration spaceflight. And for many years, NASA has followed what we call the Spaceflight Health Requirements Document, or SHIRD, as we like to call it. However, over the last couple of years, as we've been looking at the vision for exploration, we've been reconsidering the contents of that document. And we found that in trying to communicate to what is an engineering predominant agency, that if we communicate about the crew or the occupants of the spacecraft as a human system, that seems to resonate a little bit better with the engineers that we're having to convince that we need medical systems aboard. And that certainly resonates better than just talking about pure health care. So we have developed a document that we currently entitle the NASA Spaceflight Human System Standards. And instead of SHIRD, that would be shh. But we're not really trying to keep it quiet. We're actually wanting to promote that. And within that document, we have tried to define several things, such as fitness for duty standards and levels of care. So when we talk about levels of care, we're talking about what we want to take with us. What preventive strategies do we want to take? What diagnostic capabilities? What therapeutic capabilities do we want to have on board? And of course, that is in engineering parlance, sort of the in-flight maintenance, if you will. What is it going to take for us to keep our crew healthy and at their peak performance, or as peak as we can get it? And within the document, we described 6 levels of care. And, trying to think about that, it's kind of like when I left my house this morning to come to this conference, I didn't put a medical kit in my car. And so, when we do a taxi flight from into low Earth orbit going to the space station, we're likely not to carry much medical care with us. But as we get out further and further out of low Earth orbit into much more complicated missions, the need for a greater capability is going to be there, or at least we think it needs to be there. But as we get further and further out, we think, well, we need to carry more and more with us, and we need to be more and more autonomous in how we are able to conduct that medical care or care of the crew on those long-duration missions. But that needs to be balanced by reality. And the reality is that we're limited in today's technologies with power, mass, volume of our current design of our vehicles. And we also need to keep in perspective, what preventative strategies we are going to entertain prior to the flight to make sure that we launch the healthiest crew possible. So as we try to establish those levels of care and establish, what we want to take with us, we need to rely on a certain amount of evidence or knowledge, and we gain that knowledge through various capabilities. And of course, it depends on, the crew complement, such as whether or not you're going to, have a CMO, a crew medical officer, that is, or whether you're going to have a physician aboard or a physician engineer. You have the caregiver capabilities that may help you define what equipment that you're going to take with you, for example. Mission duration, the mission objectives, of course, are important. How long it's going to take you to get back to any kind of definitive care, whether that be in orbit or whether that means landing and return to Earth. The health and performance of the crew as they've embarked on this mission. What's your baseline? What are you going to try to keep them to? What percentage of that pre-flight level of fitness and performance do you want to try to maintain? What are the probabilities of a medical event occurring in space? What is the risk, the acceptable risk your program wants to take on? And then, of course, how do you balance what medical care or just overall care of the crew do you want to balance, you want to maintain in space versus any kind of terrestrial standard? All of these are very difficult. And then, as Dr. Poole pointed out in yesterday's sessions, we have technologies that are advancing all the time. And if we lock in today to a certain type of technology for exploration as we design this vehicle, we may be missing capabilities to take care of more and more issues in austere environments if we can somehow figure out how to work with the advances in technology. As I mentioned a few minutes ago, we need to rely on an evidence base. And our panel today, I've asked to make some various comments regarding where we can gain that evidence from. Certainly ground-based experiences, in-flight experiences, research experiences, experiences in analog environments, all help us to gain knowledge in these various areas. So our first speaker this morning, Dr. Mike Barratt, I'm going to ask him to make some comments about ground and in-flight experience. Mike?
Okay. Thanks, Mike. Well, first of all, I want to say I'm also very happy and honored to be here. It's a reunion for me in a way because I've been able to reunite with some of my colleagues, both U.S. and Russian, I haven't seen for quite some time. I'm the backup for Mike Fink, the Mr. Happy Crew's productive crew guy, and I'm trying to be a happy and productive backup for him, but I would say that I'm learning a lot from him. He's actually a very success-oriented mission completion kind of guy, and I would have to say, to add to what he said, that a successful crew is a happy crew. There's many metrics that measure the success of your flight, and completion of your mission is right up there. I want to break out the events that have actually happened in flight from a clinical medicine standpoint. And I'm going to caveat this by saying that you cannot separate clinical medical events from other events that happen in spaceflight, such as those with normal adaptation to weightlessness and those associated with environmental concerns. However, I'm going to do that. Remember that you have to temper your clinical medical picture of a person depending on what level of adaptation he's undergone in weightlessness. But at the same time, we're developing an occupational health model based on the events that we have actually seen in flight, and that's why we have defined the level of care we have. It's been an evolutionary process, and often we get frustrated with how slow things work, but if you look at the sum total of human spaceflight over the 40-plus year period, this process has actually been very active and agile. Things have happened in flight. We've been able to change our medical capabilities accordingly. And what we have now in flight is very much a process of active evolution in the level of care that we provide for space station. The other thing I'd like to mention is that space medicine is a very active field. It's practiced on a daily basis. It has been certainly for all of the ISS years and all of the Mir years, and certainly before that. It's something that we more or less know how to do. It's something that we operate in a zone that's acceptable risk from a medical standpoint. Can we get better? Absolutely. But it is a very active field. And for us going to the exploration backdrop, it's taking another step. We're not looking for breakthroughs, so to speak, in the clinical medicine world. We're looking for just taking the next step in covering the accepted risks and in covering the identified occupational problems that we've already seen. So with that, I haven't seen a single PowerPoint presentation here, which means that we haven't been able to really transmit the detailed information that we are all used to seeing and forgetting the next day. But I would like to give you a flavor of the medical events that we really have seen in flight. And these are not exhaustive. The denominator is the sum total of human spaceflight, so it's a very broad experience space. But this will give you an idea of what's led to the medical capabilities that we have right now in flight. Again, I'm separating out the normal adaptation processes, bone loss, muscle loss. Those happen, but they don't really breach the clinical threshold by and large in flight. But those that do, back pain, motion sickness, we certainly see that, headache. I'll put sleep disorders in there, although that's, I think, very much noise and related to factors that may not be just weightlessness. But we see those very common. And I would add that among the highest level of use of medications that we find on board, analgesics for back pain and headache, sleeping medications because of these sleep disorders, decongestants. These are probably the big three that we use. And, of course, during the first several days of flight, motion sickness drugs. From the environmental standpoint, noise-induced headaches, probably. Hearing compromise. We've seen displaced hearing thresholds that have, by and large, returned to normal. Toxin exposure, including coolants, combustion products, carbon monoxide included. We've seen contact dermatitis, which is, as I think all of you know, very, very common, one of the most common complaints in any industrial setting. Carbon dioxide headaches are fairly common. Inhalation injuries, including the celebrated event of the Apollo-Soyuz crew, which required hospitalization post-flight because of nitrogen tetroxide exposure. Trauma, many, many events. Rick Sherring and some of his colleagues are publishing a paper soon. It's in press, which will document and quantify a lot of the musculoskeletal injuries that have happened over the sum of human spaceflight. But it's in the mid-hundreds or so of the events that we've had. Very common, most of them minor. Lacerations, abrasions, puncture injuries. We've had traumatic injuries related to exercise equipment as well and to restraint systems as well. If you look at any health club's roster, you'll find the same thing. You'll find exercise equipment-related injuries in almost any setting where you have a supervised exercise program. Those are the places that tend to report them, so it's probably underreported in the real world. Smoke inhalation, we've seen thermal and chemical burns. From a cardiovascular standpoint, dysrhythmias, early in the history of human spaceflight, we've seen them. We haven't really tag them to attributable causes of yet, but we've seen them. These have led to medications being prescribed in flight. We've altered EVA schedules. We've influenced crew returns based on dysrhythmias that have happened in flight. These include PSVTs, sustained ventricular tachycardia, and bigeminy, which happened on the lunar surface, and probably the onset of coronary artery disease that was diagnosed during an in-flight period. Genitourinary, we've seen acute urinary retention, which required and responded to catheterization. There's been one case of probable in-flight renal stone, and, pardon me to flip, certainly urinary tract infections on a couple of occasions. From skin standpoint, some overlap lacerations, abrasions, contact dermatitis again, a lot of superficial wounds related to EVA, fitting the EVA suit and working against it. Abrasions are very, very common. Electrode irritation, we've seen conjunctivitis, and many skin problems. Dental problems, there's several instances of toothache and gingivitis. Neurologic, we've seen entrapment syndromes, lumbar radiculitis, some of these related to prolonged restraint at workstations. Infectious disease, probable prostatitis with sepsis, food poisoning, again, urinary tract infection, cellulitis, and behavioral psychological standpoint, depression, anxiety, grief reaction. I will stop there from listing these. There's probably a certain amount of shock value that goes with that, but again, if you consider that the denominator is the sum total of human spaceflight, it's an incidence that's not that big. I would characterize most of these events as not unique to the weightless environment. Most of them are very common if in any occupational medical setting. These are bread and butter diagnoses for the most part that you see. They're very much related to the work environment. And I would also mention that the vast majority of these, there are certainly some exceptions, but the vast majorities would not have been preventable by selection means. They're very much related to the occupational environment that the individual is working in, and also the vast majority not related to post-flight sequelae. I think Mike had asked me to mention some ground events as well. I can speak mostly from the U.S. Astronaut Corps, and that we tend to be an active and perhaps even accident-prone lot. Sprains, strains, and fractures, herniated nucleus pulposus, all of those occur with greater incidence on the ground in the astronaut population compared to controls. For surface exploration activities for Lunar and Mars, obviously we don't have that much experience. We do have some. I think that we can add pretty much to the list that we've seen such things as musculoskeletal trauma. We expect that to increase with surface activities. We did see back strain essentially on the lunar surface associated with core drilling. Dust irritation, respiratory irritation from dust, we'll see probably abrasions and mostly overuse injuries. Again, these are very much oriented towards occupational health problems that you would see in similar settings on the ground. I'll conclude by noting that as we go further, again, we'll be taking a next evolutionary step covering mostly what we've seen from an occupational medicine standpoint. But the big paradigm shift is going to be towards clinical autonomy. Right now we have a scenario of fairly easy return from low Earth orbit. We have ready communications, which includes real-time imaging guidance and real-time procedure guidance. But what we need to do is to learn how to decrease our dependence on the ground to provide that occupational medicine health model as we go further. Communication delays are going to prevent that. Certainly the possibility of return is much lower. So what we essentially have to do is use the ISS as a wind tunnel to test independent systems, possibly shifting away from some of the standard paradigms such as telemedicine, at least from a real-time standpoint, towards true clinical autonomy. And for that, I'm sorry, you will need physicians. Okay.
Next, I'm going to ask Dr. Yuri Voronkov to speak.
Okay.
Up to now, we've been talking about sending the healthiest and the strongest into space for our space missions. But Dr. Voronkov not only has been involved in those kind of selection activities for the cosmonauts, but has also been involved in the spaceflight participant activities. And we're going to think a little bit now about his experience with regards to sending the less than perfectly healthy into orbit. Dr. Voronkov.
Okay, thank you, Mike. I'm sorry. Для меня лучше, если я буду говорить
It is easier for me to speak in Russion, if you don't mind.
Прежде всего, хотелось бы, как и
Besides
Майку, I would like to thank the organizers for this excellent summit that we have the privilege of being here, Dr. Alfred and Dr. Abby. Thank you very much. They created the opportunity for us to have this open dialogue. And this is a very unique dialogue we're having. Many of us know each other, but we're not just mere acquaintances, but we are friends. And we have a chance to exchange our opinions in this great atmosphere. And sometimes the opinions we express, we don't even agree within our institute. And it's really gratifying to have this opportunity, especially since we're talking about the long-duration missions. These issues are very important. A long-duration mission is a very critical, very complex mission. Mike, are you an engineer more, or are you a doctor? Are you both? And when we talk about the medical requirements and the medical standards, and it's very difficult to understand these issues, even for those professionals who dedicated their whole lives to medicine. Today, I'm really satisfied with the level of the relationship between Russia and US, being the manager at the IBMP Institute. This good, friendly relationship allows us to be very productive and develop a set of requirements for long-duration flights. The requirements and the standards are not always the same. Some standards are very different in US compared to Russia. Nevertheless, for the last 15 years, we have enjoyed a great progress and great cooperation and developed, I would say, volumes, A, B, C, on crew selection, on commander selection, flight engineer selection, the research cosmonauts. That's how we call them in Russia. And we have spaceflight participants. And in Russia and at NASA, we have our internal documents. Mike, you can confirm probably that at NASA we have MERT document. In Russia we have our own internal documents from Ministry of Defense and Ministry of Health. Nevertheless, despite the fact that we have a set of our own internal regulations, we have common documents. We were always able to find a common denominator when making joint decisions. And the decisions are made by Jeff Davis and Dr. Pachuyev for spaceflight participants. And the other boards never were dissatisfied that they did not participate in the spaceflight participant selection. But these two individuals are ultimately responsible. And we were talking about the pregnant alcoholics yesterday. So for right now, we didn't have any spaceflight participants who are pregnant and who are alcoholics who want to fly. But nevertheless, who knows? And of course, we have been discussing these sets of issues from Rio de Janeiro, and we would like to participate in further developing these standards. But nevertheless, in the future, we hope that we will have a chance to unite FAA, NASA, Russian medical organizations and develop a set of documents with one common standard or a set of requiremms for cosmonauts. I would like to say that we single out maybe not 6 levels, as Mike, you were saying before, maybe a few groups. Nevertheless, we have similar standards as you were discussing from Group 0, when we don't have to administer any measures, including the countermeasures. But this is a very artificial or theoretical division into groups. Because yes, the discussions we had yesterday and today confirm confirm that it's difficult to select somebody absolutely healthy. It's usually level 1, not 0, because we have to train them on the ground. And somebody mentioned that 18 days was sufficient for Mr. Sevastyanov, who was flying, to encounter some health problems, despite a very stringent selection. So we have gained valuable experience in medical training and countermeasures, and I think we have the right to be proud of our achievements. And I think the U.S. side has changed its opinion about the long-duration flights and its approaches, and that's a great progress. I'm not going to enlist all levels. Level 1, when we believe that the candidate is ready for special medical training on the ground, and this individual does not require any special medical attention, be it a diet or countermeasures. Second group, or second level, is when the space flight is less than 30 days. The third level we have, the space flight is less than 30 days, but outside of the normal orbits, as we call them. Group 4, probably Group 3 is suborbital flights, and Group 4 is the regular orbit we have, and Group 5, any flight which is over 30 days, which will include Mars and Moon. We don't agree exactly with this selection or singling out of groups. Why are we talking about 210 days but not 400 days? You know about Valery Polikov. So we would have selected 400 days. And these information, this data requires the discussions between the agencies. But what is truly gratifying, that we were able to find the common denominator. We now speak the same language, and this is a great achievement for the last 15 years. We have the same set of standards and requirements, and the concurred and approved documents that we have make our lives easier and make it easier to work internally in our agencies. I'd like to emphasize once again that the approaches that we use, they didn't come up yesterday and not even 15 years ago. We started developing them at the end of the 50s, and we all know that we started our work long ago, and Mike Barratt knows, and we were writing some chapters together with Mike Barratt for the monographs. Nevertheless, it took us sweat and tears to develop those requirements, even though we had different approaches initially in selecting crew members, commanders. Before, we believed that only test pilots could be in charge of the mission. Now we're changing our approaches. And this was a lot of work involved in developing those standards. And once again, I would like to thank for this opportunity to come here and exchange our opinions. I don't want to take too much of your time, but I think it's excellent. And I have prepared the presentation. Should we have any time available later, then I'll be happy to share. But I'm a very law-abiding citizen, therefore I'm not showing my presentation because I was banned. Dr. Alfred, if you invite me next time, maybe I'll show my presentation. That is how to use statins when there are coronary diseases, and I think it's something that we worked for the first time, and maybe Richard will be able to listen to me when we have the asthma discussions. Thank you very much.
Thank you, Yuri, very much. Excellent comments. As we continue trying to define our evidence base, it is the analog environments that provide us a lot of insight as to how we might approach long-duration spaceflight. So I'll ask Dr. Cristianato to give us some comments.
Thanks, Mike. I'd like to provide some of the medical perspective on long-duration missions, and these would be missions of a year longer from the analog point of view. We've only had, as of last year, 1,401 people winter at South Pole Station, spending a year typically with a winter over, and that's in its 50-year history. And in fact, we've had more people summit Mount Everest, just over 3,000 as of last year, yet South Pole offers this incredibly vast data pool in comparison to the 4 cosmonauts who've lived in space continuously for a year or longer. I think we really have a limited understanding of the profound effects of this kind of isolation and confinement, and that's based on my experience. I think that analogs can play a key role in the training progressions of long-duration crews and in developing strategies and countermeasures to reduce our risk of mission failure. In terms of space medicine, I think the areas in particular importance are obviously the crews, which are a clinical population, and secondly, you've all heard about the enabling technologies that can actually extend our autonomous care capabilities. And lastly, being a physician, I can't forget our on-site medical expertise, the crew medical officer. And these 3 areas have been really strong clinical drivers in pushing the limits of our care capabilities in the Antarctic program, and at South Pole in particular. In terms of our clinical population, we've heard a lot about behavioral health, and I think behavioral adaptation is going to be essential for these long-duration missions. In long-duration spaceflight, we'll be subjecting crews to an unprecedented duration of isolation, confinement, monotony, and an incredibly hazardous and threatening environment. In fact, you heard Dr. Leroy Chow yesterday mention that he was struck by how he underestimated his preparation for his long-duration mission on ISS. Now, a 30-month Mars mission is going to be 5 times the length of current ISS rotations and 2 to 2.5 times longer than the 4 longest continuous spaceflight records. So one has to ask themselves, what effect will this have on crews? Well, we know from our Antarctic data that there are often profound cognitive and behavioral changes that we see in winter over personnel, which we've attributed to the isolation and confinement. And we actually see that these changes increase over time during the mission. Specific things that we see: social withdrawal, lethargy, somatic complaints, tension and irritability. We see hostility, overt anger, territorial behavior, decreased concentration, other cognitive effects like short-term memory loss, operational errors, and even depression. It's quite funny. In fact, you'll see the majority of winter overs will have a mild aphasia at the end of their 1-year stint, where they'll actually have word-finding difficulties. And this cluster of symptoms is so common in our winter overs that we've termed it winter over syndrome. And one of the most striking observations for me was how closely winter over syndrome mimics Russian spaceflight asthenia. So much so that I feel they're a common syndrome. And in fact, I think they're caused by neurostructural changes at the level of individual neurons due to neurohormonal and neurochemical alterations as a result of chronic stress. And I had an interesting conversation last night with Sarah Lynn, who's an endocrinologist, and it was an interesting chat about that. In any event, this is supported by cutting-edge neuroscience over the past 5 to 10 years in the area of stress research. And these neurostructural changes are manifesting as behavioral change, so winter over syndrome in Antarctica, or on spaceflight asthenia or space stupids on orbit. The precipitating factor is the cognitively depleting environment that we subject these explorers to. Long-duration missions are cognitively depleting environments. Crews are isolated and confined from a majority of the very things that define us as being human, and have done so over the past 150,000 years. And this is clear. This is stressful. But I'm a firm believer that there's quite a bit we can do in terms of selection, training, and countermeasures to alter the trajectory, if you will, of these neurostructural and, as a consequence, behavioral changes in long-duration missions. The second area I wanted to address was enabling telehealth technologies, which have played an increasing role in the care capabilities of our station medical officers. And we have a comparatively large clinical population, which has been the driving force in pushing the limits of this technology, and as a consequence, the impact on mission objectives has been minimized, which is important for us. And as an example, ultrasound plays a key role in medical imaging at South Pole. In fact, we looked at the 66 clinical ultrasound exams we conducted at South Pole and McMurdo in 2003, and the majority of ultrasounds were transmitted in a store and forward format, 94%. We only had 6% of exams done in real time. And what really surprised us was the largest clinical effect was actually in preventing an intercontinental medical evacuation, and that was in 25% of cases. So that's staggering, the costs that go into just a single medical evacuation, and they're an order of magnitude higher in winter versus summer. So obviously this confers a significant operational benefit in terms of avoiding the loss of personnel and a redirection of logistics resources. And in between 2002 and 2004, we reviewed all of our telehealth consultations at the 3 U.S. Antarctic stations, and there was a total of 117 telehealth consults actually performed in 15 different medical specialties. So a very broadly based program. And again, store and forward consults accounted for the vast majority, 62%, and that outnumbered real-time consults almost 3 to 1. And that number would have been higher, but during that period we had quite a few psychiatric consults. And telephone or voice link accounted for the balance of that. So what's interesting is that we found a direct relationship between the remoteness of the station and the number of telehealth consultations as a percentage of total medical visits. So South Pole, our most remote station, had a consult rate of 3.4%, which was 7 times greater than McMurdo at 0.5%, our most accessible station. So of all the patients that present to medical, 3.4% needed a telehealth consult at South Pole versus only 0.5% at McMurdo. And interestingly, Palmer, which is our second most inaccessible station, was in between the two at 2.5%. Well, higher than McMurdo actually, but less than South Pole. And there was a similar relationship in the total number of telehealth consults per patient problem. So each individual that needed a telehealth consult, they may have needed 1, 2, 3, or 4, however many. In the case of the knee surgery that was conducted in 2002, I think there were probably 12 telehealth consults for that. So at South Pole, each patient problem that required a specialist consult required 4 times as many telehealth consultations as McMurdo, so approximately 4 for each telehealth problem versus 1.2 at McMurdo. And again, Palmer was in the middle at 2, which was our, it's in between McMurdo and South Pole in terms of accessibility. So I think this data demonstrates that the more remote the polar station, the higher the overall consultation rate, and the higher the number of follow-up consultations per patient. And what this tells us about the station medical officers is that essentially they had a good grasp of the diagnosis at the outset of the consultation, but sometimes required greater guidance regarding treatment. And this is consistent with the breadth of training of our station medical officers, who are comfortable with a wide range of diagnosis. They're all primary care physicians, but may not have the same level of comfort regarding the long-term care of illnesses that would normally be transferred to the care of a specialist. And being so inaccessible, it's often difficult to evacuate the patient, so there's more involvement in extended care. And I just want to note that our medical officers deal with the vast majority of cases on their own. Those 117 consults represent only 2.6% of all medical visits, which were 4,500 over that period at our 3 stations, and approximately 2%, 2% also were medevaced over that period. So we know that the transmission times during a Mars mission will preclude the use of telepresence or real-time assistance, but the experience that we've acquired in the Antarctic program in autonomous medical care, I think, shows that the majority of general telehealth and imaging consults can occur in a store and forward format, which is conducive to deep space missions. So I think mission planners should expect to see a definite need for telehealth consultation on a Mars mission when timely repatriation to Earth is impossible. And I'll make a brief comment about our crew medical officers. As we've seen at our Antarctic stations in life-threatening emergencies, it's the crew medical officer who will be relied upon in terms of administering their medical skills and training in terms of saving the patient. And in 2005, we had our worst trauma at South Pole Station. It was blunt chest trauma with 5 fractured ribs, tension, pneumothorax, and hemothorax as well, with bleeding into the mediastinum. And so this individual required trauma-level care. No amount of telehealth was going to aid this individual. He needed the skills of a primary care physician. So we worked on him for 7 hours, stabilizing this individual, myself, physician assistant, one of the carpenters, the carpenter assistant, the physicist, and this is the sort of scenario you're going to see, on a long-duration mission. And we activated a walking blood bank for the first time in the 50-year history of South Pole, collected 4 units of blood to transfuse into this individual. And we had a Herc scrambled from McMurdo and picked him up and flew him to Christchurch Public Hospital. And I'm happy to report this is an 05 that he's wintering this year, and so it was successful. So, thanks.
Thank you, Christian. Very interesting comments. I'm sure will generate a lot of questions for the group. Next, Dr. Ellen Baker has been involved in recent months as we've attempted to review our human research program, look at our knowledge base, and establish where we need to improve our knowledge. And I'd like for her to make some comments about our research and how this can help us establish levels of care.
Most of my comments are disclaimers. We've talked and heard a lot over the last day about areas of research and areas of physiology and operation that we really need to look into a little more in depth. But when I look at this, I'd like to make some assumptions, and I'm kind of a lumper, so I kind of lump things together, and I like to make things as simple as possible. So here goes my assumptions and my disclaimers. I think it's absolutely critical that we do a better job of cataloging our data, our historical data, our medical data, our research data. It's unfortunately in many, many different places, and I think for us to really benefit from our prior experience, we have to do a better job of looking at that data. And I don't consider this research. I mean, we've referred to this as data mining, but in my opinion, this is our responsibility. Anytime we collect data, we ought to handle it in a way that is responsible and beneficial, be it medical ops data or research data. And I think we need to do a better job so that we avoid repeating mistakes, we avoid repeating research, and we really get the full benefit of everything we've done. And I would love to see this done in collaboration so that we get the benefit of the global space experience from everybody who has that data. So that's sort of one of the big disclaimers. And I think once we do that, we'll be a lot further along than we are right now. And hopefully that will redirect what our priorities are in the future, because we will find that maybe we have more information and a lot more confidence than we thought. The other is, to the greatest possible degree and the most reasonable possible degree, we have to screen out disease in folks who are going to be traveling far from Earth and far from good medical care. And this will severely reduce the likelihood of development of disease during these missions. And not only will it be of benefit to the crew, since they will be less likely to be develop any illnesses, but it also reduces the needs for hardware and the need for crew training. And so there are many benefits that maybe you wouldn't normally think about when you do that. We do a pretty bad job of screening out some disease, and part of that is just the state of current medical knowledge and medical testing. And I'd like us to become a little bit more aggressive in doing that as the missions become a lot more challenging and as we're spending more and more time further and further from Earth. The other thing is, I think it's important as we go forward to the greatest degree possible to engineer out the risk of injury, and that's through the design of a vehicle, through the design of the spacesuit, through the design of tasks and tools, and make the risk of injury very, very small through this effort, at least as small as you can. And as you're designing out the risk of injury, think about designing in ways to augment crew performance. I'm all for doing everything you can here on the ground and having to do a lot less when you have very limited resources and you're far from home. And then to the best of our ability, use training and the support necessary to ensure good group functioning, good crew performance. David Dinges told us yesterday that no matter what you do, mistakes are going to happen, and I think that's true, but certainly we can do better than we're doing now, and we ought to really strive to do that. And I'm not sure that we do all of this in a really well-integrated fashion. At least at NASA, historically, the medical community and even the human factors community have been late in getting involved in things like vehicle design and even spacesuit design and task and tool design, and it's almost an afterthought, and I think being involved from the start would be of great benefit in keeping the crew healthy. I'm not including in any of this the need for advanced technology, and that is a huge area to ensure good air, good water, and good capability for monitoring the environment. And I didn't include any of the research needed to develop advanced technologies for medical diagnostic and therapeutic support, though these are important. And I expect in the next 10 years we'll have better capabilities, and I would hope, like Mike said, that we don't lock ourselves into a technology or some kind of method that is outdated by the time that we fly it, and that's another thing that we tend to get hung up with. I think we should continue to document normal zero-G physiology to broaden our understanding. I think we still have a ways to go in this, and part of that might be the fact that we haven't really compiled our data well, but I think that's a reasonable thing to continue to do. And then just before I get to my short list of things I think we ought to focus on, just to the research community, I would say keep your tasks simple and keep them focused and keep them operational. I think the likelihood of getting useful data and getting good crew participation and coming up with some real operational solutions is more likely if we really focus our research and keep it as simple as possible. And one other thing, typically in the research world, we look at individual physiologic systems as if they are totally independent of each other. And I think the time has come for us to look at things in a much more integrated and physiologic sense. And I'll mention one activity that we're involved in now that demonstrates that. But I've always had a hard time trying to extrapolate what it meant if my quadriceps muscle strength was down 15% after flight and trying to say, okay, well, what does that mean I can do or I can't do? And to me, that's been a huge problem in a lot of our research. It's very hard to go from what we find in the lab to what your real capabilities are or your disabilities are. And so I would love to see us work together, the musculoskeletal folks and the neurovestibular folks, to look at a real integrated picture, and that would give at least the crew and the program something that is a lot more concrete to work with. Okay, so those are all my disclaimers and my assumptions. And, I just put together a really short list of things that I find are interesting and somewhat important. It's not an inclusive list, but we talked about radiation, and obviously that's going to be a big issue for a long flight. We have a large amount of uncertainty in what we think the risks are associated with radiation, and there's no question that we need to reduce that uncertainty. But we also need a lot of effort for better shielding and, of course, a faster transit time. And those are problems I think we just have to solve. And I don't know what else to say about that. Certainly we've talked about that a lot. Bone mineral density is something that we talk about as well. think the risk of fracture, at least in our combined experience, is pretty low. I don't think we've had any in the U.S. I don't think there's been any in the Russian. I mean, there's no question there's reduced bone mineral density. What does it really mean, and what are the real risks associated with it to the individual? Doesn't appear to be in-flight fracture. We don't lose that much in the duration that we're talking about. Is it a risk for long-term age-accelerated osteoporosis, something like that? I think it's reasonable to continue to look at that. In my opinion, the primary concern is sort of post-flight long-term issues. We've talked a lot about crew performance and the behavioral and psychological issues. The one real obvious issue that I think everybody in here would agree on is that the crew gets fatigued, and fatigue is definitely an issue when it comes to performance. But I sort of look at the big thing, and Mike can comment on this, Mike Barratt, but training for a long-duration flight is incredibly rigorous, and I don't know how many trips Mike and the other crew members make back and forth between Moscow and the U.S., and you don't really get much of a time to get over your jet lag, and you're thrown into an incredibly rigorous training cycle. I don't understand how Mike is not trained yet because he's been working so hard for so many years, but we tend to overwork the crews and then we launch them fatigued. And so it's kind of bad to start your mission fatigued. And, then there are many things that work against you in flight, and I think we all know about changing your sleep-wake cycles and the slam shifting and all of that. And so fatigue is an issue, and I think it's something that we ought to address in a little bit more proactive way. And it might be something like David Dinges talked about yesterday in developing a self-assessment tool, but certainly as those of us who maybe sit in mission control or the control center and Moscow ought to make sure that the crew schedule and the crew sleep and wake cycles are protected, and we could probably do a better job of that. I mentioned about, losing muscle strength. What does that mean? I guess I would look at the whole musculoskeletal thing as fitness, strength, and endurance. And from a more practical aspect, how can we maximize the efficiency of our exercise, maximize our fitness, specifically to reduce the overhead of exercise on orbit? It's a huge overhead, and it's not just the time you spend exercising, it's the volume and mass of equipment you have to send up and the amount of time you spend repairing and maintaining that equipment. So in addition to just your normal scheduled 2 hours of exercise time, there's a lot of overhead. And if we could improve the efficiency and ensure that the crews have a good degree of fitness, I think it would buy a lot for the program above and beyond what you think of when you think of human performance. Just a couple of other things. We've got reason to believe that perhaps the shelf life of drugs on orbit is affected, and those are things we need to document and assess, and the nutritional quality of the food, whether or not the vitamins and minerals can be maintained while they're on orbit. So those sorts of things I think we need to understand, and we're in the process of doing that now. And then I'm going to end in talking about the integrated research effort that I mentioned earlier. We have an ongoing effort now to look at ambulation on planetary surfaces, and we have the engineering community and the EVA community involved, and we've got the musculoskeletal research community and the neurovestibular guys involved. And so when I say an integrated research program with real operational benefit, that's what I'm talking about. And so it's not everybody looking at their physiologic system. It's working as a group together to look at performance, and performance is a result of many, many different aspects of physiology and engineering and task and design. And to me, that's how you get the biggest bang for the buck, and it's the most benefit not only to the crew member but to the program. So I would love to see us do this in other areas, with the aim of improving the engineering and everything from design to the task completion, and include the person as part of that system. That's it.
Thank you, Ellen. I appreciate those comments and perspective very much. As our last presenter on the panel today, I've asked Dr. Volker Dahmen to make some comments regarding collaboration, about how we can all work together. it's been my pleasure to get to work with him and get to know him over many years of working with the Multilateral Medical Operations panel. So, Volker, your comments, please.
Okay, thank you, Mike. I think we have to remind ourselves that the construction of the ISS is for the first time in human mankind an endeavor that 5 global players are really trying to do together. I think it's the first time, and we always have to think about that such a big enterprise is done across borders and across cultures. Also, as a disclaimer, because that seems to be fashionable, with even some critical words I will place in my talk, I have to say I'm not necessarily happy with the way many things are running, but I'm confident that what we did and what we believe in is the right way to do it, and there is always room for improvement. But I think if we want to continue in exploring space, there is no other way than to cooperate, to collaborate, and to work together beyond political and cultural boundaries. I think it's also worth noting that the space medicine community of all 5 partners already in '96 realized that crew health is not an agency-specific issue. It goes across the board. And so that was leading us to developing an integrated medical support concept that at that time was very innovative. It still, I think, is innovative in the space program, and it is even provocative. It scares a lot of people in the way that we collaborate and cooperate in the medical domain. We were seeking for synergies. We tried to integrate and we tried to collaborate. And there it is again, this word, this famous word collaboration. I think we heard it 100 times yesterday. So let us analyze, what does it really mean? Looking back into, again, European roots, Roman literal translation of collaboration means working together. It does not mean, it means working together. So to work towards common goals, common policies, utilizing each other's strength and protecting us from each other's weaknesses that, of course, all of us have. And finally, it's all a matter of trust. Collaboration is a matter of trust. In its original intent and in the meaning of the word, collaboration will move us forward, will move us as a whole forward, will protect us also from external entities that try to destruct or to interrupt our processes. It makes us strong. And again, with that, Europe has provided, even if it's only a linguistic element, but it has provided the ISS program with a term that we all use, collaboration. And as a side remark, Jeff, you're smiling, and Mike, I have to see how much it is worth. What is the value of the term collaboration that ESA provides to the ISS program, to barter it for services that may come up? However, if you have listened closely to the discussion yesterday, apparently collaboration comes in different flavors. There's a different understanding of what collaboration really encompasses. And there is the criticism, because I think we may sometimes have different opinions about the collaboration. To some it means cooperation. But I think also from a linguistic point of view, cooperation is not collaboration. Cooperation is you're running parallel. You may have some interfaces and a common goal, but that's about it. But you just do your work one by one next to each other. That's not collaboration. And amazingly enough, we barely used that term cooperation in yesterday's discussion. It was all about collaboration. Collaboration also is, in a collaborative program as ISS, is certainly not to compensate financially for scientific participation or data exchange. And it's also not within the multi-partner program to set up a bilateral program setting aside the other partners, or even worse, running 2 parallel unilateral programs. We also have to be aware of the fact that the term collaboration may be politically and programmatically abused to make people believe that we are all a happy family. It may also be abused as a hollow term to cover unresolved problems, or even worse, to divert us from the true problems and intentions that are at stake. Isa and I, myself, are true believers in collaboration. There's no other way, by the way, as a small partner, to move forward. You have to collaborate. And Isa and I myself in the space medicine community will see to defend the collaborative nature of the space medicine program now and also for the future.
Thank you, Volker. Appreciate your comments. We've taken up pretty much an hour of this hour and a half panel discussion. I think it's time to open it up to the audience and see if there are any questions. Yes, sir.
We need a mic.
As a panel moderator, I can do that too.
This is collaboration.
First of all, I commend Ellen Baker for her comments in that we need to look at an integrated approach. Being an exercise physiologist and a muscle biologist, I certainly resonated with the comments that she made, and I think it's important in which to do that. As anyone who has taken Medicine 101, we all know that the skeletal muscle system is the organ system of movement, so you have to start with something. And I think we've gone through an evolution here in knowing that there are deficits in muscle, and now the question is, how does it fit into the big picture? And I think that's where we need to go. So you get no arguments from me in my area. I am concerned, though, with the future directions in order to do exactly what you have outlined, because I'm sensing that there is a movement afoot in which we don't want to put devices up there in which to ensure efficient and economical ways in which of maintaining optimal fitness for achieving the fitness of duty that Mike mentioned in the outset of his comment. So I don't think we can move to an area where we're going to use EVA as the way in order to maintain fitness, and thus we need to find out what are the best devices that fit into the constraints that are being proposed for moving stuff to the moon and beyond in terms of how we can achieve this global way, which I see is the essence of preventive medicine. So I laud your comments, Ellen, and I'm willing to work with anybody to ensure that they get implemented. Thank you.
Thank you.
So, Mike, this is actually for Mike and Ellen, and I'm interested in the topic of adherence here. And Mike, with regard to events that have occurred in spaceflight, have there been any problems around that have developed because of misuse isn't the word I want to use, but I'll use it. Misuse of medications or a failure to adhere to an exercise protocol. In other words, and Ellen, for you also. So, how do we connect over the adherence issue to the likelihood of a medical problem developing?
Well, I'll start by saying I'll repeat one of my disclaimers, which was my list was in no way exhaustive or 100% inclusive, and probably there have been medications mistakenly taken on orbit, just like they've been mistakenly taken on the ground. Have they breached the clinical threshold? By and large, no. And if they have they impacted mission operations? By and large, no. Certainly there have been overuse and you could say maluse injuries coming from exercise equipment. But this is one of those areas where weightlessness does play a role. Biomechanics are different, and typically these show up in the first several days to a couple of weeks of flight. We've had some anomalous reactions to medications in flight, but by and large, medications do in flight what they do on the ground. A few years ago, Joe Ortega and Mary Ware and I forget who else published a paper just looking at the subjective response of crew members. When you get a headache and you take a Motrin, does it work? The answer is by and large yes. So typically those do not seem to be problematic to us with regard to completion of the mission.
If I could just follow up. So, Ellen, I think your point about the concern about, I forget quite how you put it, the just basically the amount of time that might be required to engage in countermeasures is a really seriously important point for long duration. We know from studies on Earth of adherence, and I've run panels for NIH on this, looking at the literature, that if you could get people to adhere to protocols, we could prevent a lot of suffering and misery and disease and death. But it's very hard to get people to adhere, and particularly over long periods of time. And so I think reducing the burden of what has to be done to maintain certain physiologic systems is going to be important. On the other hand, they have to do something in spaceflight. So from a behavioral perspective, you want to keep people active, or at least they have to have flexibility in it. So I think it's a very good point, the issue of adherence. We need to think about that, not just from UPMAS, but from people's willingness to even adhere to protocols.
I'll have to defer a little to Mike Duncan on that. I think in general the adherence to the exercise protocols has been pretty good in ISS, but there's a lot that goes into that. You need to build good exercise gear that doesn't have a lot of disincentives to using it. So you don't want something that's so complex and so onerous that it's like, oh no, it's, time to do this again, and it takes 30 minutes to get ready and 30 minutes to clean up. So you really have to consider disincentives and things that will enable the crew to be to adhere and to participate fully. But I think in general our track record's pretty good. The big problem on ISS has been the exercise equipment's been fairly unreliable, and the overhead of maintaining it has been enormous, and it was a lot more and a lot worse and a lot uglier than we ever predicted.
I have a question to Dr. Otto. Yesterday we started the discussion of the analog environments, and as far as the Antarctica and polar wintering, the first question is, we're talking about performance all the time, that we want the crew to do the excellent performance. This is the criteria for many issues. At the same time, I think that performance could influence the intensity of performance, the variety of performance, the quality of performance could influence the psychosocial state of the crew. And from this point, the first question is, how much is the workload at the Canadian polar wintering, and how much it could be comparable to the intensive work rest schedule of the space crews? And second question, very brief. We are here on this panel, we're talking about selection, but how much the problems with selection could be covered by training? I mean, you mentioned a lot of psychological, physiological problems among the polar crews, but how much you could diminish these problems, not by selection, but by the training and countermeasures before the mission? Thank you.
Thank you. I think they're excellent questions. In terms of, I think what you're referring to, operational intensity, that's an enormous problem for us, enormous. And again, within the context, and I work with the United States Antarctic Program. Canada doesn't have an Antarctic program, but medicine really within the Antarctic program is such a small area. And we try and do the best we can, but science really is the driving force there. And over the past 7 years, we've been building a new elevated station. So the operational tempo and intensity has been intense, very, very intense. And in fact, 2005, we had our largest winter over crew we've ever had, 86. And also one of the most stressful in terms of crew stress, etc. And it's an enormous issue, particularly from the medical side, and we've had a lot of discussions and battles because it's a large contributor to the stress that we see and the stress load and the increasing stress. And trying to we've tried to advocate for increasing rest and less work as the mission continues. And we see periods of operational intensity during the summer season, 110 days, construction, science, materials, etc. coming in. The operational tempo is very, very intense. We have 300 flights to South Pole during that time. And then we close for winter, and then everyone is quite tired and they're breathing a sigh of relief. And the winter is a much more steady pace, but we work 6 days a week. 1 day off. We only get 2 days off the first weekend of every month, and to endure this month after month after month is exhausting. And it's clear to me that this is contributing to winter over syndrome. And when we extend this scenario to, say, a Mars mission, you're going to have periods of increased operational tempo, leaving the Earth, entering Mars orbit, descending, making the habitat operational, and then, of course, leaving. And I think you're going to see a continuous performance decrement. So I think it's very, very important, those issues, and it's one of the things I think we need to get a handle on. In terms of your other question, I think that selection, training, and countermeasures all have very important roles. I think that you can identify individuals who are have great aptitude for long-duration environments, and then I think it's very important to take those individuals and put them through appropriate training flow to draw out and strengthen those scenarios. I think psychological training will be very important. It'll be one of many issues, but I think everyone will have to be aware of their own psychological limitations. They should endorse psychological countermeasures. This isn't to prevent them from doing their jobs or prevent them from flying. It actually improves their experience. And I totally agree with David in terms of monitoring. It has to become part of the mission. And we felt it ourselves at South Pole. There's definitely an inhibition to psychological support. I found that with the individuals, and also in terms of myself, when I found myself being stressed as the mission continued, there was a reluctance to reach out. And in retrospect, we would have all been better off if we were more accepting of the psychological support. So I think training will be very key.
I just want to ask a few more questions about the winter over. If it's something that you see repeatedly and you even have a name for it, what is the prevalence? What are the upper and lower boundaries of it, if you can describe that, and what do you do about it, and how effective are whatever, your selection or your countermeasures or whatever? Have you studied it in any systematic way?
It really hasn't been studied in a systematic way. A few people have taken brief snapshots of it. Larry Palinkas has done a lot of work. He was involved in a very nice study looking at group interaction at South Pole, which told us a lot about effective groups, ineffective groups, leadership, etc. There has been, however, no systematic studies. Larry did a little bit of cognitive testing. His N was very, very small. We only had about 8 to 10 people at South Pole. I love operational research, so I was a really happy person there. You do your clinical duties during the day, go get some exercise and have dinner in the galley, and then go off and comb through our medical data. And we looked at our data over the past 10 years, and that's where we came up with this sort of stress response curve. We looked at individuals presenting to medical with a psychological diagnosis, insomnia, anxiety, depression, and adjustment disorder, and we had a grab bag of counseling, which we couldn't differentiate what that was, and we actually see it steadily increase, peaking in the third quarter. Unfortunately, there has been no systematic approach to dealing with winter over syndrome. And as a physician and as an operational medical researcher, I feel that's a real failing in the program, because I think we can make life much better for individuals who spend a year at South Pole. And personally, I think we're doing them a disservice.
Dr. Poole?
Yeah, my comments are relevant to Dr. Dahman's comments. As you walk into this institute, one of the challenges perhaps you look up and see is this institute is to provide a bridge between the world of ideas and the world of action. And with that in mind, how do we capture the wonderful ideas such as Dr. Dahman suggested this world of cooperation in the future with regard to the Moon and Mars missions. And while the politics of all that sort out at higher levels, perhaps one of the things that you could do is to utilize the relationships that have been built in the MMOP and the MSMB to look at things like the level of care, the kinds of things that you would decide you would be able to treat, the training levels and that sort of thing by some sort of perhaps utilization of the talents of those groups, maybe some sort of subcommittees, et cetera, you figure it out. It's just a thought to try to bridge the gap from the ideas that we're having to some sort of positive action over time.
Yeah, Dr. Poole, I think those last 11 years with a lot of growing pains, but I think it crystallized that there is a theme, underlying theme that we have developed and that we have expressed in our meetings, and which we have luckily also documented in how to provide medical care to our astronauts. And I'm a little bit afraid that there is a gap opening, that there is a discontinuation of what we have achieved so far. And that's why I raised that issue a little bit more critically, because I just want to protect this intellectual endeavor that we have gone through and the expertise that we have gained, and translate that into the next stages of spaceflight. Open to any suggestions how we do that. We don't have the mandate as ISS community, MMOP, MSMB, and all those different medical panels to work on exploration aspects, but certainly maybe there is some institution or some, I don't know, structure that will help us bridging the gap and keeping also small players on board and to contribute and to collaborate.
Dr. Kowalski.
I have a question to Helen. I'm wondering, Helen, how could you combine two points which you presented in your talk, which I liked very much and agree with most of what you said. But there were 2 points which for me looks very difficult to combine. One was about necessity of integration studies to provide integration when to understand what is behind decrease in my performance and behavior. If it is necessary to have data about the behavior, the first of all, and performance, then the data about the state of those systems which are involved, like muscular and neuro, as you mentioned, and the central nervous system, and so on and so on. To get this data, it requires, you talk here about diagnostics, that for diagnostic you need better technology and better skills, but to get the scientific data, it requires better technology, better skills, and time. And then there was the other point when you addressed to us scientists, make your tests as simple as possible, as short as possible. How to combine two of these lines?
Well, I didn't say it'd be easy. I said those would be goals, and you ought to keep them in mind when you set up your studies. And sometimes having lots more information doesn't necessarily give you lots more benefit in terms of the result of the study.
You're right, but without information, that will be just speculation.
Well, I'm not saying don't get any information. I'm just saying maybe keep it a little bit more focused than we have in the past. Yeah.
Jeff, did you want to make a comment?
If I could make just one comment, there are the comments this morning were very, very good. There are some examples of moving in the direction of integration that you're talking about. We've had a joint bed rest project, for instance, where the protocols, the methods of data collection, the sharing of data were pre-agreed to. The artificial gravity project was another good example of deciding on the types of data to be collected ahead of time. So we are moving in that direction. It's not necessarily easy to go back and retrofit all the other studies and data that we've had, but we have recognized that, and where some of the better outcomes from the study so far, absent results, have been standardizing the approaches, the methodologies, the data sharing collection right up front. And so the lesson learned from us, from the bed rest study and from artificial gravity, is do that work up front. It'll pay many, many dividends down the road. So we are moving in that direction. The other quick point I wanted to make is we talked about risk management yesterday, and we are trying to fit all of our work into a risk management format spread across the mission so that we really do try to work on the right things at the right time. And that's very much an evolution, and that's another whole discussion and topic. But I think those two things speak to integration. So we've realized the value of that. We're moving in that direction.
Thanks, Jeff. Dr. Canis, this will be our last question.
Yeah, just a comment about the use of simulations in psychological research. I think Peter Sudfeld said it best, in my opinion, when he said that it's not the simulation, but the psychological meaning of that simulation. And I think that the use of a simulator, the Antarctic, or we heard yesterday about the submarines or bed rest, captures some of the variables that are of importance to space travel, but not all. For example, I would argue that in a way it's more isolating to be wintering over in the Antarctic than to be in space. And perhaps this third quarter phenomenon that some, but not all, Antarctic researchers have found is related to this idea of not communicating and being trapped and confined with that population in an Antarctic environment. Whereas in space, where you have open communication lines to your family on orbit, you can talk to people, it diffuses some of that. So I think it's really important to pair simulation research where you can capture certain variables, amass higher subjects, maybe get it funded, as one source of information, and then paralleling it with space research, where you actually are studying people in space as well, and to see the differences based on the variables you can capture. I think the two go hand in hand, both in simulation analog environments and in the space environment. So I would just argue that it's important to also study what you find on analogs in space as well, and see how the two match and pair together.
Thank you, Dr. Canis.
Comment, Mike? Quick comment. Yeah, I agree in part with you, and my comments are directed to long-duration space flight where there are severe communications limitations, where there's no real time. And I think if we're comparing South Pole to ISS or even the lunar station, yeah, there's less of a comparison. But I think when we're talking a 30-month Mars mission, then they are far more applicable. And as Ellen and I have been discussing, I think a polar experience or some kind of analog experience like that is just one module in a training flow for long-duration space flight.
It's 10:30. I'd like to thank our panelists, and I'd like to thank all of you.